Good evening, everyone. I'm Dr. Shailesh Khode, consultant snoring sleep apnea surgeon at Tarabishi Stamberger Ear Sinus Institute, Dubai, as well as Gargash Hospital. And I'm a visiting consultant at NMC Royal Khalifa City, Abu Dhabi, as well as NMC Align. Uh, it is my privilege to moderate this ninth Gulf SLEEPENDO Lounge meeting this evening. And on behalf of our Gulf SLEEPENDO Lounge faculty and collaboration with the Tarabishi, I would like to warmly welcome you all. So we built this unique platform where the ENT surgeon, dentist, maxillofacial surgeon, sleep physician, and other expert can openly discuss the challenging cases and learn from each other. And as I know that following the great success of our last eighth Gulf Sleep and Lounge meeting, which was open to the delegate for the first time, so we all of us decided to continue the same program to invite wider audience so that we will discuss interested sleep management cases so we can learn and collaborate together. So overall, our vision is very simple. It is to create the practical case-based discussions to promote the interdisciplinary management plan so that we can understand the patient management and improve the care for them. So here we are delighted to all of you. Welcome to this meeting. Thank you very much. And to start with, I would like to introduce our panelists. So Professor Peter Baptista is a consultant senior sleep apnea surgeon from Navarra, Spain, and he's an internationally renowned sleep apnea surgeon with extensive peer-reviewed publications and authored book in this field, and a pioneer in the hypoglossal nerve stimulation program for obstructive sleep apnea. Our another panelist is Professor Dr. Hisham Al-Rais. He is a senior ENT consultant and deputy commander at King Hamad University Hospital, Bahrain. He is also an associate professor at RCSI Bahrain and co-founder of Vitality Medical and Sleep Disorder Center at Bahrain with expertise in the sinus endoscopic surgery, sleep surgery, and advanced head and neck cancer care. Another faculty is Dr. Jessica Schwartz-Pumar. She's a ENT specialist with advanced training in sleep medicine and sleep surgery across Venezuela, Chile, Mexico, and a board member of SIBECS and an active member of ISSS and European Surgical Research Society, a lead hypoglossal nerve stimulation program at American Hospital, Dubai, and was the first female sleep surgeon who performed this procedure in the Middle East. Another faculty is Dr. Nicole Perez Blanc. She is a Mexican Spanish board certified ENT specialist based in UAE since 2011 with a training in allergy and clinical immunology from the Foundation Germes Diaz Madrid and the faculty member in the various conferences. Now here I would like to introduce Dr. Tina Rokadia. She's a dental sleep medicine specialist based in Dubai for last 2 decades, qualified by the American Academy of Dental Sleep Medicine with expertise in airway, focused dentistry, and lingual phrenotomy, and lead the Airway Study Club and lecture across the multidisciplinary sleep forum. Uh, uh, Professor Muhammad Al-Zajmi, unfortunately, is not able to join for some emergency concern from his side. So here I would like to introduce uh, Dr. Ahmed Al-Said. He's a consultant assistant professor at King Saud University, Riyadh, and he's completed residency program from the Dalhousie University, Canada, and a sleep apnea fellowship at Stanford University. He serves as an evaluator for the Saudi Commission of Health Specialties in Sleep Apnea Surgery. Thank you all of you for continuous support, dedication, and commitment to advancing this sleep program in the Middle East region. Now it is my great pleasure to introduce our today's guest faculty, Dr. Professor Srinivas Kishore Sisla, an eminent ENT and head and neck surgeon and the director and head of the department of otolaryngology at AIG Hospital, Hyderabad, India. He completed his MBBS from Manipal Academy of Higher Education in 1991 and Masters of ENT from Kasturba Medical College, Mangalore in 1999. With a 3 decades of extensive experience in the sleep apnea, he established himself as a highly respected clinician, surgeon, academician, and teacher. He has a national and international faculty all over the world, and he is serving as a board member of the International Surgical Sleep Society meeting. So we are privileged to have him here today with us to share his knowledge and experience. And so please join us me in warmly welcoming Dr. Srinivas Kishore Sislia. Thank you very much for joining us, sir. Highly appreciate that.
Thank, thank you. Thank you for
So
having me. Thank you.
So before we start our meeting, just to highlight few agenda and objective of this meeting. So overall, an idea is to establish the collaborative interdisciplinary sleep board in that all the ENT, physician, dental, and other faculty can contribute and discuss the real-time case base, which is on ethical basics. And here we are also talking more opportunities in for the academic activities in the Gulf region. So we try to add on new sleep friends from this in the SLEEPENDO Lounge Meeting, those who have done the fellowship training programs, those who are enthusiastic to be the part of the sleep apnea management. We are also share at the end what are the upcoming sleep meetings for gathering and update us. And also we encouraged for to research innovation, to think about some new ideas and experiences, so that we can to collaborate together. So here our image, our vision is very simple, you know. So we are focusing more on the education and the case-based discussions. So at the end, of course, I would request all the panelists and the faculty, including the delegates, to give your suggestions and guidance how we can make this more informative. So before we start our case discussion, I would like to start with the audience poll question. So can we have the question, Edward? Just to all the panelists and the faculty, I can say that this is a very open forum. So there is no restrictions. Anyone can put their any input about the poll questions, about the case discussion. So can we have some questions for our audience? Yeah. So there are three questions. The first one is, before offering a patient sleep surgery, what is your typical approach to obtaining sleep study? You personally order, or patient refer to the pulmonologist or sleep physician, or you don't consider the sleep study is necessary, or you rely on the prior sleep study. You just need to scroll down so you can answer all these questions. Mhm. Edward, can we have the vote and poll? All right. Okay. So yes, so about almost 70% they said they order personally, and around 30% they refer to the pulmonologist, and 5% they can rely on the prior sleep study. So if I'm looking at the sleep study, what they prefer, I think it's 50% they said it depends on the patient clinical picture. But 1/3 they said it depends on the level 1 they prefer to go. 18% they do the home sleep study. Regarding the sleep endoscopy, and almost 50% says, 40% they say yes, they do. 40% they say on selected cases. And around 20% they mentioned that this evidence is still insufficient. So, Dr. Hisham, any comment on this audience poll from your side?
Well, it's very interesting, seriously. And I think it's different schools, different prospects at looking at things. Now, what needs to be bear in mind? For example, if we go for simple septoplasty or nasal surgery, at times patients might not snore before surgery, but at times they mention that they've started snoring after surgery. Okay, that's like a simple thing to keep in mind in general. How about somebody who you operate on, he's a snorer, and now after surgery, his snoring persists, like you do only limited nasal surgery. You don't go for complete, let's say, dicing him at the same sitting. So to me, if I'm going to do a nasal surgery and the patient's the snorer, then at least I'll have some like packed up with some information in my bank that I can utilize and even discuss with the patient subsequently. And I think it's also like at times people come to you and they like have ear blockage. You think it's more of a retracted drum, then you do them an audiogram for future, just in case they come to you and you have it there. So I think it's I like the answers. Yeah, it's diverse, but I'll be more obliged to do dice whenever feasible. Like if I'm operating on somebody, he's a snorer, even he's not obstructing, I would like to see and then learn, because that's like also a learning process that we go through.
Dr. Srinivas, any comment about the sleep studies in your practice? You always prefer to do the hospital-based, or you have some balanced choice, depends on the patient clinical picture?
Good evening, everyone. I was not sure if I had the chance to greet all of you. So to answer your question, Shailesh, I think as the selection that you've given in the questionnaire that you have asked, it has to be patient specific. Every patient doesn't need a level 1. Similarly, there are some patients who definitely need uh, uh, HST, which is home sleep study. And then here in India, we have a unique combo wherein we can actually get level 2 studies done at home. But it has to be patient specific. You cannot have a one size fit all strategy.
Yeah. Dr. Srinivas, would you like to give one example for a home sleep study and a lab-based? Just any typical
Sure,
example?
sure. So the dictum is that if you have a patient who you think is highly suspicious of obstructive sleep apnea, and you think and you know that the patient has no comorbidities, you can definitely go for a home sleep study. On the contrary, if you're not suspicious, the history is a bit vague, and here's a patient with a bunch of comorbidities or somebody who takes a lot of medication for multiple problems, it's probably a good idea to get either a level 1 or at least a level 2 study.
Right. Dr. Ahmed, any comment about the DISE in your practice? You do all the patients with the DISE before you offer surgery, or you also go with only selected patients?
No, I actually don't. So for the dice, I need to have a few boxes checked before I actually proceed ahead with that. Number one, I do like demand a sleep study before I do a dice because the validity of the dice in distinguishing normal from abnormal patients can be a little bit hazy, meaning that I would need to have a diagnosis of OSA before I actually proceed with a dice in order for me to be able to use the dice in guiding my management. And the second aspect about drug-induced sleep endoscopy that a lot of people don't really realize is that it can lead you astray, particularly in the hypopharyngeal structures, because it's a technical procedure. It depends on the choice of anesthetic. It depends on the anesthetist providing the anesthesia. It depends on the operator itself. There's around 60% inter-rater variability when it comes to rating the hypopharyngeal structures. So in that case, I reserve the dice for very specific indications. I have like 5 or 6 indications personally. Number one, if there's a like inconcordance between the sleep study, the symptoms, and the physical examination. If someone has had an upper airway surgery from before, and I would like to understand the dynamics of the upper airway. If the patient is undergoing a big procedure like maxillomandibular advancement surgery, I also use that to help me in planning the case. And for people who would undergo upper airway stimulation, particularly for Inspire. That's very important to rule out concentric velum collapse. And then finally, this is something that is developing, but I use it for titration of therapy. So people who have failed CPAP, who have high pressures on CPAP, and we don't really have an explanation as to why those high pressures are required. And for people who are candidates for oral appliance therapy, but for some reason they failed, or we don't really know how much to advance them with oral appliance therapy. So those are, like, in summary, my indications for a DICE.
Right, thank you. A quick leading question to Professor Peter. Regarding the sleep study, do you think so? You see that 27% they said they refer a patient to the pulmonologist. So do you think so, as a ENT sleep apnea surgeon, personally we should order and score the sleep study by ourselves, or we should completely dependent on the pulmonologist? Any quick comment on this, Prof? I think Professor may be busy. So, okay. Any comment from JC Nicole about this, about sleep study, or Dr. Srinivas?
I think that the obstructive sleep apnea is coming from the airway, so from the upper airway. So ideally, it should be approached by ENTs. Okay. Now, it's been a field that has been explored by the pulmonologists for so long, and in the last maybe 15 years, the ENTs have been like more interest on develop the sleep studies like approach in the upper airway, especially of this kind of patients. But from my point of view, if you are a sleep surgeon, it's a must. Should be done by the ENT. Now, it will depend in the context of the place you are and how the rules are. Huh?
Perfect. Thank you. I think we should proceed from this audience poll. We're heading towards our first case discussion. Okay. Right. Okay. So I'm going to start our first real case discussion. So she's a 26 years old female, single, BMI 25, no other comorbidities. She's on braces for malocclusion and to fill the dental gap almost for last 1 year. And in 2020, 2019, almost I can say 7 years before, she did a nose surgery, septoturbinoplasty for some breathing difficulty blockage issue. Current her IPOS score is 11, stop bang is 3. She fall into the mild risk of obstructive sleep apnea. But her main concern is snoring. And she has a poor quality of sleep. That another, even specifically, she mentioned that even after 10 hours of sleep, she doesn't feel fresh in the morning. She had intermittent daytime sleepiness, not that significant, but she concerned also about the dryness in the mouth. And on top of, she gives a history of recurrent tonsillitis, not 6 to 7, but 3 to 4 episodes. For that, she might need to take the antibiotic. And also, she is concerned about some halitosis. Now, on the examination, her neck circumference is around 37. Allergic nose, grade 2 turbinate. Septum is functionally straight. It is not giving any obvious obstruction. She is on braces. Friedman tongue position is 2, no tongue tie. But she has a high arch palate, not that significant, but it is there. She has a grade 2, I can say grade 3 tonsils. She has a thick, soft palate with slightly long uvula. Not slightly, it's a long uvula. And she did a polysomnography in January 2026 in outside facility, not by me. Sleep efficiency was around 86%. Sleep stages, I can say that N1, N2, N3, pretty much in the normal range. AHI 6.2, RARE is 8.8 per hours. Respiratory distress index is of course 7.8, slightly increased. Lowest saturation is 92. So when I'm looking at her symptoms and the polysomnography, it gives me an impression that sleep study says she's having a mild apnea, but she's concerned about the snoring. But if I look at the snoring percentage, is just 4.5% of the sleep. But she's also said that she always snore even in the supine right and left position, and that is her main concern. And daytime, she doesn't feel fresh and energetic, especially in the morning time. So I'm gonna take it further. That's a sleep endoscopy. But before I go ahead, any comment from the faculties or anything else you want to pick up in the scenario from the sleep study? Dr. Hisham, Dr. Srinivas, anyone?
Just
Shailesh,
just a
just
comment.
Yeah.
Sorry, sir. Please go ahead.
no, please. No, please.
Yes, Dr.
Speak.
Srinivas.
Yeah. So, just a comment. Actually, when it comes to women and sleep apnea, when you go back to history, right? Stop bang is not a very accurate screening tool for women because it is
Absolutely.
so gender biased.
True. I
Because
do agree.
if you're a woman and your neck circumference is not that high and your BMI is not that high, you automatically drop off,
True.
right?
The
So
scoring is
stop
from
bang,
7.
yeah. So
Yeah.
stop bang as a screening tool for women probably is not one of the best tools.
Mm-hmm.
But if you really look at the symptomatology, these are classical symptoms how a woman would present,
True.
as opposed to the typical how a man would present with excessive daytime sleepiness and loud snoring, which still seems to be the big
Yeah.
concern. But
Yeah.
poor quality of sleep, intermittent dryness of the mouth, and probably if you dig deeper, she will have more symptoms in terms of fatigue,
Yeah.
early morning headaches, and
Yeah.
things like that. And that exactly is reflecting in the sleep study that you have shown me that there are RERAs,
Yeah.
and that is driving the RDI up.
Yeah.
And if you can actually maybe see what is the AHI in REM, because in women the REM AHI would be much higher, and if you look at the REM percentage of sleep, it also seems to be a little low. But then, if the patient had very high REM AHI, you could completely sort of say that all these symptoms are because of sleep apnea, and probably, as you correctly did, would investigate further.
Yeah. And also she mentioned that, she's a little bit anxious sometime, a little bit irritable. I'm just trying to find out the RIM AHI. RIM AHI total index is, yeah, its RIM index is 19.1.
There you go.
Yeah,
It's
yeah.
classical.
It's a 19.1, right?
It's
Right.
classical.
Yeah. So I just open her sleep state. Perfect. Right. So now, of course, so she was seen by another ENT, some another facility, and they offer her to do the traditional U triple P. She had a nose surgery. They said, we do the U triple P for your snoring. And somehow she Google discuss and she turned up to me for the second opinion. So she said, I don't want to do U triple P. I'm a young. Can you help me with other option? She also got offered to use the CPAP, but she doesn't want a CPAP. She's a young female. She said, can you help me? And of course, her sleep study doesn't support to prescribe the CPAP if I'm looking at the AHI and getting, uh, uh, covered by the insurance. So, of course, I offer her sleep endoscopy, and that's a sleep endoscopy. So if you look at my screen on the left side, that's a heart rate, that's a saturation. Here is the blood pressure, that's a bispectral index. And you can see her, so that's her nose. Because she pray every day and all, they do ablution, clean the nose. So she used to scratch, so there is some blood staining, but it is not trauma. You can see the turbinate is great too. We can see some scarring over there. On the left side, you can see that there is no as such turbinate left to her. I think she underwent some intramural abrasion, but I think the bone didn't survive. So it looked like almost a turbinectomy kind of situation. So I go ahead further. Nose looks pretty good to me. Some allergic changes in the skin. Right. So I'm trying to lead it. So look at that's a palate, and that's a posterior pharyngeal wall. During endoscopy, I found some post-nasal drip, but it is not that significant. Uh, That's how the palate is in contact with the posterior pharyngeal wall. give me an impression that mostly anterior posterior. Saturation is 88. That's a
Shailesh, can you rewind so that we can see the upper part of the velum,
sure.
just to see if the alpha angle. Yeah, yeah, perfect. Thank you so much.
Sorry, I start again.
Yeah,
Okay. Sort of the volume is not that loud. Somehow I didn't get that when I was recording. But now she starts snoring. Not that loud, like a male. But yes, there is a snoring. Look at how the palate in contact with the posterior pharyngeal wall. I slowly go down, and if I little rewind, that's her left tonsil. I can say the grade 1 lingual epiglottis looks normal in shape, but how it's a crescent shape, and it slowly fall down independently without any involvement of the tongue. That's what I'm getting an impression. But
again, the shape of an epiglottis is a predictor for epiglottic collapse. And as you correctly said, that kind of a shape can sort of give a predilection for epiglottic collapse.
But on the side, I can see that as the tongue is sitting at one place, there is a window on the both side
Yes.
that make her breathe and reduce the effect of Bernoulli's. You can see she has a grade 3 tonsils, uh, quite big. Go a little bit
Ganesh,
further.
can I ask a question? How was her awake endoscopy in the clinic in reference to the
So
epiglottis?
epiglottis is pretty much sitting well. It's pretty much sitting well. I do it awake endoscopy in a semi-sleeping position, right?
Mhm.
And I do Muller's maneuver, but I didn't see much changes in that. Uh, Epiglottis was pretty much okay. Even the BIS is around 68. It's not that bad. Now here I do Ishmarch maneuver. So just for sake of knowledge for our delegate, Ishmarch maneuver in the clinic, I do the assessment of the jaw movement forward and backward by using the roller to see that how much maximum they can do forward and backward. If it is around 10 millimeters, so I can take it around 7 millimeter is the maximum, maximum measurement for the oral appliances. And same I try to mimic during the sleep endoscopy just to get an idea, is there any role of the oral appliances? So again, I'm at the velum a little bit. So now it's like a jaw thrust. We slightly move the jaw by putting the finger around the angle. And you can see by moving the jaw, epiglottis is sitting pretty much well, quite stable tongue. The time we release the jaw, we find that it's a little bit, make the epiglottis come in touch with the posterior pharyngeal wall.
Can I
And with
ask a
the,
quick question? Sorry.
yeah,
What
yeah,
were the braces? She was wearing some braces, right? So,
yeah,
so
that is for the mal alignment and to feel the dental gap. She wanted to align her teeth to fix the feeling the gap of the teeth.
so there was no like she didn't have any retrognathia that was meant to be corrected because it's very impressive, no? How much
Yeah.
it.
Yeah. So I'm coming to the next slides where Dr. Tina is going to help me with that. So she will answer that question to you. Definitely. Right. So see by moving the jaw, I found there is improvement at the level of the palate a bit. Tongue base, of course, it is pretty much good. Then I turn her to the left lateral. The palate, of course, it's quite collapsible. When we are putting patient in the left lateral, we found a little bit rollover of the tongue, a bit of epiglottis. You can see the hanging tonsil more prominent on the right side. Right. So yeah, so left lateral pretty much good.
Dr. Kodai, a quick question. What is the anesthetic agent used for the drug-induced sleep endoscopy here?
Okay, so what I do, I practice. I give some midas, little bit, and glycopyrrolate at the beginning. Maybe in the pre-op room if my theater is okay. Otherwise, in the theater, uh, very mild dose. So we reduce the secretion. Then we start on the dexmedetomidine. That is the drug of choice. I do not encourage my anesthetist to give propofol. I wait for 10 minutes time and I go very slowly, very slowly. I do not decongest the nose. I do not spray the nose with the lignocaine. So Dexmed is my drug of choice. But out of five, one of the patients, sometimes they give a little bit small dose of propofol. So yeah, so it's a combo. I can say that Midas and Dexmed is always there, but sometimes they add a little bit of propofol. Yeah, sorry, my apology.
Shailesh, can you
Yes.
allow me to ask Prof. Ahmed? I really did like the checkbox evaluation, and it's very logical and reasonable. Now, the question, if this patient was this patient, would you have diced him or her? Sorry.
Good question. So I probably wouldn't. So, like starting from the back, what I would have done differently is I would have had her fill out a questionnaire for fatigue symptom score. It's a validated questionnaire for MS that can tell us that it can quantify her fatigue. The second thing that I would have done differently is I would have gotten a sleep study with esophageal manometry, a level 1 PSG with esophageal manometry on those young females, particularly because the AHI is not necessarily indicative. AHI is based on middle-aged men, so it might not show like the burden of her condition. But it at least gives us an idea of how much upper airway resistance, in this case, when there's a discrepancy between the RDI and the AHI. And then based on the information that I get from those two important metrics, I would decide whether or not I would dice her. So if she was more fatigued than she is sleepy, like comparing the fatigue symptom score with the Epworth Sleepiness Scale, and her esophageal manometry did not show significant upper airway pressure discrepancies, I probably would have treated her conservatively first with an oral appliance device if possible. But I mean, clearly in this case, she already has orthodontia, so it might be very difficult to get an oral appliance in her situation. But I would at least try positional therapy, giving her a little bit of time to adjust. And then if that fails, I would dice her.
Okay.
Thank you.
Right. So there are a few more snoring event, mostly the interval flutter. Right. So then I've done the tongue palate interactions. See, that's the tongue, and that's her palate. That is her uvula. And during inspiration, it's get full and come in contact with the tonsil. You can have a look for the tonsils. Okay. So that's a sleep endoscopy because she turned up to my clinic by someone offer you triple P. So in that case, I offer her dyes, and that's how she look like, right? Uh, okay. So to take it further, I discussed Dias to say that she's a young, mild sleep apnea, REM AHI is bit high. She doesn't feel fresh even after 7 to 8, 10 hours of sleep, intermittent, daytime sleepiness. And I said that there is a improvement in her airway, with a jaw thrust. So I refer her to my colleague, dental, to evaluate her because my approach is all the way, to go more conservatively, but she was also concerned about the recurrent tonsillitis and halitosis. So, yeah. So I involve my dental colleague, and that's how she's having these braces. Okay, straight. So I refer to Dr. Tina, and she evaluated her from the dental point of view to find the candidacy for the oral appliances. Anyway, we can help her in terms of myofunctional therapy, or we can offer her in Europe appliances. Dr. Tina, would you like to comment on
Yes,
this?
sure. Thank you. Yes, this was rather interesting because it needed a sort of different analysis. It's usually, very helpful to work with the team where, when referred, we usually go ahead with the oral appliances. It's most of the time straightforward, but she was really interesting. So I'll just give you a little bit of what I was seeing in the assessment. First was that, Dr. Shalesh's dice showed that velum collapse continued despite jaw advancement. So while tongue base and epiglottis had shown improvement, the velum collapse was still present. And then this is somebody who actually said that this was her fourth round of orthodontic treatment. So she's clearly somebody who cares about how her teeth look, one. Two, she mentioned that the spaces between between her teeth keep opening up. This to us, typically in the dental world, is a sign of tongue thrust. Or let's just say that the muscle area of the tongue space is not enough, and therefore it seems to keep pushing teeth out of alignment. So if we actually put her into an oral appliance, she's firstly just 26 years old. So yes, I mean, she was clear she wants to get married, she doesn't want to be on a CPAP, etc. But how long is she going to be able to keep this oral appliance as a permanent form? The oral appliance is likely to cause bite changes in her situation because those teeth, the minute they're left without retention, they tend to move 4 times. So somebody who cares about their teeth and their teeth are highly likely to move, it is a bit risky to put them in an oral appliance at a young age and risk bite changes over the years. Further assessment into her jaw. So she had what we call a jaw deviation to one side and then coming back towards the center. When palpating the muscles of the TMJ joint, she actually had pain just on one side and also on palpation of the disc more than muscle, so possibly a little bit more than just myalgia. So TMD is not a contraindication for oral appliance therapy. It's just something that we have to manage. But when I put together the third aspect, that presently it would be very difficult to put her in an oral appliance because she's still finishing this round of braces. So we can do like, change the liner, etc. But it did not make sense for me to put her with these three aspects in place. Somebody who cares about their teeth tend to move constantly, presently in braces, and present TMD symptoms unilaterally in at a young age into an oral appliance. Adding on, she was okay with the procedure for the velum, which was suggested by Dr. Shailesh. And then came in what was going on with her face, things that I think we can see here, even that we don't have with the tongue. There is a severe hyperplasia of the maxilla. And what we didn't capture here was a significant vertical growth pattern. So when we actually saw her on a lateral cephalogram, the sagittal airway dimension, which, all right, we understand it's just, standing, it's not sleeping, the airway behaves differently, but still the anatomic dimension of the airway and the sagittal position was quite low. And she's been a complete vertical grower. In 4 rounds of orthodontics, nobody has suggested that she should actually have intrusion of those maxillary teeth or possibly surgery. So the flatness of so she would actually be an excellent candidate for double jaw surgery. And even at this point, she could be one if she was guided accordingly. But the hypoplasia that you can see in these aspects means that it is unlikely to have a long-term solution from my aspect. So I was like, I'm going to put this 26-year-old in an appliance, which is presently going to make her TMD worse. And the challenge is, at the end of the day, the narrow palate. And for me, TMD is often a sign that the tongue is not doing what it needs to do, or it's not resting in the right place, hence not bringing muscle balance to the picture. So what I suggested was that she go ahead with Dr. Shailesh's plan and then consider some myofunctional therapy. And then we reevaluate where do her symptoms of mild sleep apnea, potential REM-related sleep apnea, or UARS stand. along with that.
All right, thank you. Quite comprehensive. Any
I have a
comment
quick
from?
question. Yeah, for
Yeah.
Dr. Rapadia. Would you be able to comment on the transverse dimensions of her maxilla? I mean, clearly from an AP perspective, it's quite
Yes.
hypoplastic. Transversely, she has a bit of a crossbite as well.
So she is very edge to edge. She's very edge to edge, but she's been brought into a class 1 occlusion. And she definitely is very narrow. She's at 34 millimeters with an extremely high arch palate. So these pictures are actually after the procedure with Dr. Shailesh, but even when we saw her originally, it's an extremely high vaulted palate, which has also been the challenge with the nose. So she would be a good candidate for all kinds of orthodontic intervention, right? Whether it was a dome procedure, a MARPI, a double jaw surgery. These are all aspects that should have been discussed for the vertical grower in that. And while Dr. Shailesh's assessment says that there is no tongue tie, I'm not putting it off the table. I feel like there could have been a component of a posterior tongue tie resulting in that vertical growth to be reevaluated after myofunctional therapy.
Okay,
Right.
I mean, at her age, like 26, would you consider a MARPI? I mean, she's clearly has been a mouth breather for all of her life, most likely. So would you still consider that? Would you do that?
I do think that she would be a great candidate for it. Now, I don't do MARPIs. I would refer to an orthodontic team. But you know, Dr. Ahmed, it is so hard to discuss that with a patient who has had orthodontics 4 times and is now looking forward to these brackets coming off in a couple of months. So, you know, it's just human to human. You're like, oh my God, that's going to be another at least 2 years of teeth alignment in place. So presently, I did not think, I mean, I did suggest it to her, but it was really hard to tell her that nobody has considered intrusion or expansion in these 4 rounds of orthodontics.
Thank you.
Right. Okay. So she came to me for the second opinion. She's concerned about snoring, young lady, poor quality of sleep, halitosis, tonsillitis grade 3. I did a diet. I convinced her, you are not a good candidate for surgery at the first place. You have done the nose job. You have a mild apnea. Better you go with oral appliances. She went back to Dr. Tina, again turned back to me with the say that doctor, help me with my snoring apnea, and can you help me with at least with my tonsils? I also give her, I said, why don't you try the CPAP as a trial? So she said, no, I don't want this machine and all. At the first place, also, she refused to do that one. So it was a big catch for me. What should I do ahead? So now I was thinking about, shall I consider something? Anyway, I need to do the tonsillectomy for her. So because of the recurrent tonsillitis, I said, just doing the tonsillectomy is not going to sort out the problem. But I cannot offer her a typical, release the palatopharyngeal muscle, pull it forward, suture it, to fix it to the technique. So with all consent, so I just did a tonsillectomy for her. And as I see that the posterior pillar are literally curtaining to the uvula, I just release at the superior pole. I take out small piece of the supratonsillar fat pad and use the 30 PDO to just suspend the palate. Elongated uvula, I just trim the tip of the uvula, and what is that? I just trim the tip of the uvula. I didn't cut the muscle, but I use the barb suture. I've gone through the uvula and pull it back to make it a little bit shorter. So that's what I've done almost 10 days before. So that's what I thought, and I didn't do major, but I did a tonsillectomy to address her tonsillitis, halitosis, and I use a barb suture to suspend the palate. So this is open for all my panelists. Did I take the right call to touch her palate? And did I do the right procedure for her to suspend the palate, considering she's a little bit conscious, a lot of dental procedure done, mild apnea, poor quality of sleep, and I just remove the tonsil. Shall I just go ahead with the tonsillectomy only for the halitosis, chronic tonsillitis, or I really what I've done is the right call? So I can say, Dr. Srinivas, any comment on this, or how you gonna tackle this case?
I think you pressed all the right buttons, Shailesh. I would do the same. definitely would involve, and I really liked the discussion that Dr. Trina brought up about. It's definitely, I can actually see how high vaulted the hard palate is. Um, and I'm sure the nose is very narrow. I would also consider treating the allergies simultaneously.
Yeah.
I think the nose definitely. I think it's still underrated in sleep surgery. Noses, I still feel, is king, and there's a lot of work that can be done, and which can be done along with the sleep dentist.
Yeah.
And I would definitely do the Roman blinds that I think that you have done. Yeah, definitely. I would go the same path, Sailesh. But I think we should also understand and convey to the patient that OSA is a journey. What you
Yeah.
have done is a part just to help
True.
to improve her quality of life. And then, of course, with a interdisciplinary involvement, uh, you could go a long way in controlling her symptoms.
True. Um,
Can I say something?
yeah, Nicole, please go ahead.
I kind of agree completely with both of you. I think you did a great job because not only you're helping her reduce the snoring, that I think at that age it's what concerns the most, yeah, because she said that she wants to get married, and so it sometimes it's not only about the quality of sleep. That of course it is very important. It is the main goal. I will definitely do the same. And then on the dice, we've seen the tonsils that they were causing obstruction. And then I also agree with Dr. Srinivas because we remember in the dice also we've seen a lot of postnasal drip. And I agree,
Yep.
the nose is not. I will be not happy with that nose. I will definitely add some other medical treatment, like at least saline greens and a topical steroid. And if she had allergies before, I think also I agree, of course, with Dr. Tina. The high bald palate most likely is from the deviated septum and the nose and the allergies that was not addressed early in time that as it should, and that caused that vertical growth of the face. So I think, yeah, we have to catch this earlier. And anyways, I think she's still young, and maybe I will suggest the MARPI and the expansion because in the long run, she still have a lot of life to live. And despite the unfortunate events of these poor outcomes with the braces, I think she still can benefit from the expansion.
I'm
I
expected
think,
she's still gonna be a mouth breather. Do you think
yeah.
so, Dr. Tina, Dr. Ahmed? Is there any role of the chin strap I can offer her after 2 to 3 months? Do you think so? Is
So
gonna
that's
help
a
with the biofunctional?
Yeah, so that's a very good question. So I actually just published a systematic review on that topic. I think for those with mild sleep apnea, with a narrow, high arched palate, it is not an ideal treatment, meaning that we don't really have a full picture of her condition. So the sleep study would underestimate her condition, and then doing a chin strap or mouth taping can potentially worsen her condition. What I would do is have a better idea of like the burden of her disease. And in this situation, honestly, like having her so high arched and narrow, I would probably start with expanding her maxilla, if possible with orthodontia, with a MARPI. But if not possible, then probably I would go for a SARPI. The morbidity of a SARPI is, or dome or two pen or whatever it's called, is not that high, particularly in a 26-year-old. It's quite unfortunate that she had like underwent all of those orthodontic treatment, but she can probably have Invisalign, and that's not as intrusive as classic orthodontia.
Right. So, quick
I'm
question, Dr.
agree
Ahmed.
100%. I'm agree
Yeah, Jesse.
100%. I would have started like probably expanding because I think that if we don't have a good box in the mouth, they will keep with the problem. You may change small things, yeah. But I think that the approach with each patient should be like make her understand that small things probably will keep her in the same situation. So, is that okay? Yeah. I mean, it's tricky because there are many patients that they just want you to take out the tonsils because of whatever excuse. And yeah, she's worried maybe about the snoring, and she has maybe Googled or ChatGPT that if you take the tonsils out, that will be solved. And I've had these patients that want us maybe to do only the tonsils, and we know that the tonsils won't take the problem away. So the procedure was beautiful. You did it great. But eventually, I think that if we don't have enough space in the mouth, we will keep with these problems. And eventually, they will grow up with the years.
So last leading question to Tina. When would you like to see this patient again? And when I should, escalate further to refer to you? Any 2, 3 points would you like to highlight?
Yes. So first, I'll just go into your question on chin straps and mouth tapes.
Yeah.
I think those are only meant to be a crutch while you are in the process of myofunctional therapy. So it's kind of like, you're already learning better tongue posture, but it's more about tongue posture than mouth closure. And when the tongue gradually starts to stay closed, you will not end up needing the chin strap or the mouth tape as frequently anyways. I would have suggested about a 12-week follow-up for this particular patient because it
Okay.
usually takes about 12 weeks post-surgery
Yeah.
around the
3 months. Yeah.
healing, but also she was right at the end of braces with this particular provider.
Okay.
So
And
I have already created a little list for her to, discuss MARPI, but she did
yeah.
think that, let me get done with this. I'll look about this about a year later or so. And what I was hoping to see was that she had some reduction in snoring, maybe not a lifetime improvement around the disease, but as the shrinkage of the tissues happened, the tonsil removal came through. So she would also be in a better place to decide whether she would like to go down the MARPI route or move into an oral appliance, unfortunately.
Oh, thank you. Any last comment from panelist?
I just have a question for Dr. Ahmed. Um, so the question is, yes, I completely agree with you that we definitely have to treat the transverse maxillary deficiency. My question would be, uh, correct, doing a dome or a SARPI obviously is not going to correct the snoring. And of course, the tonsil issue that also has to be corrected. So my question to you is, would you combine a palatal procedure with a dome or a SARPI, or would you space it?
I honestly would stagger them. Just because like once we achieve optimal expansion and we have like a good space, that enhances the outcomes from UPPP because you have a lot more lateral leeway to actually suspend the tissues. So once you expand the hard palate, you can actually expand the soft palate a lot better doing a UPPP because you have a lot more space. So I would stagger them. I would keep like a year between.
Okay. Right.
Sure,
Thank
thank
you.
you.
Perfect. We move toward the second case. All right. Okay. Uh, so this is a 34-year gentleman, South African, BMI is 32, a rugby player, pretty physically strong. He was an ex-smoker, quit at the age of 29, no more on the tobacco use. He's a loud snorer. He said severity out of 10, 9, daily since age of 16. It's slowly, progressively getting worse. He married 5 years before, then wife noticed that he has some witness apneas and all. Then the things all started. He did a sleep study 5 years before, maybe 2021, diagnosed with a moderate obstructive sleep apnea. He was prescribed CPAP machine using more than 4 hours per night, good adherence, but despite poor subjective tolerance, he tried oral appliances as well, but he had a very bad experience in 2022 something. Now he has done the dental treatment for the alignment and he's not at all in a favor of, oral appliances. He's worried about it. Again, the, malocclusion and all. Again, he was seen by another sleep and they offer him UPPP. He researched everything. He found that there are a lot of techniques of the palatoplasties and all. And somehow he passed by and come through me to discuss more about what are the other treatment options available. Current symptoms, he has some global sensation, feeling some airway collapse. He has a dry mouth almost every night. some sore throat on waking up. Non-restorative sleep, despite of the full CPAP, he doesn't feel that much afraid. Frequent nocturnal awakening is there, difficult to resume the sleep. Daytime fatigue is still there after even after using the CPAP. He has some memory difficulty. Waking up with some palpitation, some gasping feeling. He has a nocturia 3 to 4 times. We did the bladder workup. It is normal, he said so. He got some vivid dream in the night once in a week. Sleep latency he takes is around, 1 hour to fall asleep. He said, maybe I'm putting the CPAP that make me a little bit anxious, might be the reason I'm not going to fall asleep. Position worsening mainly in the supine position. He said he has a rarely no significant bruxism. Sometimes he clench it, and he has a history of chronic nasal obstructions. He said maybe it is troubling me to use the CPAP. Something is in mind. So that is all his current scenario even after using the CPAP. Right. So any comment on this or anything, 1 or 2 points from the panelist?
Shailesh,
He's using the full nasal mask. Yeah.
Shailesh, when was the titration done for the CPAP? Was it recent or all long time ago?
He did a sleep study and he never had a CPAP titration. I have seen his rest med, and in that 95th percentile pressure is around 12 centimeter of water, and maximum it goes to 15, 16. But his CPAP was set up to 4 to 16. So I didn't know that he might be need a 18 or 20. We don't know. But his initial setting was 4 to 16 auto mode, and ramp was I don't remember that, but the 15th, 95th percentile pressure is 12 centimeter.
Any nasal symptoms?
Yes, nasal blockage, post-nasal drip, intermittent sinus headache. Yeah, so
Yeah.
he's having
Okay.
that symptoms. Yeah, yeah.
So, talking about phenotypes, right? And if you look at this patient, he classically fits into the phenotype wherein is a very high cardiovascular risk, especially with symptoms of daytime fatigue and sleepiness, and his sleep latency being more than 1 hour. This is typical of the phenotype which are more vulnerable for increased cardiovascular risk, or what we call as MACE, major adverse cardiovascular events. So basically, this patient has to be helped and treated. Otherwise, there's a very high risk of cardiovascular
Yeah,
morbidity.
very, very well taken, Dr. Srinivas, because he turned up to me to say that, doctor, forcefully I'm using a CPAP for last 2, 3 years to make sure that I'm not getting apnea because I'm afraid I might get, high blood pressure, stroke, or heart attack or something. So can you help me? Yes. Right. So he did a home sleep study. 18th October 2025. I couldn't manage to get it done because he came for a rush and all. So you can look at it. He did analysis almost 10 hours. AHI is 18.8. This is the Knox sleep device, A3. ODI is 10.8. Snoring index is 18.9. Lowest saturation is 89. You can look at it. The REM is 3.1 and N3 is 12.9. So it's not going into the deep sleep in terms of percentage. And if you are looking at it, is non-supine, it's 3 AHI, but versus the supine is 20.7. But he said, doctor, it doesn't matter, I'm sleeping supine or non-supine, I get a lot of choking, I'm not able to breathe properly. Look at the REM AHI is 28.2. Right. So as per his symptoms, giving the impression that it's a non-positional OSA, but if I look at it, sleep studies gives me an impression that it's a positional OSA. Any comment? I have only this data from his Knox 3 sleep study. Right. And come to the examination. Right. So yeah, so that's his type 2 tongue tie. He has a flickering hypotonic tongue. Uh, he can able to protrude beyond the vermilion, but it's a suboptimal. He has a Friedman tongue position 3. Tonsils are grade 2. It has some yellow spots, some tonsilloid kind of picture. He also concerned about the halitosis significantly. On examination, he has a thick base uvula, long, soft palate, curtain-shaped posterior pillar. They're almost touching the tip. I can say a few millimeter away from the tip of the uvula. He had a CT scan done, and that's how it looks like. He has a paradoxical middle turbinate, grade 3 hypotropic turbinate, deviated septum. Sinuses wise, pretty much clear, nothing major, a little bit some sinusitis here and there. So he also know about, the dyes, and somebody offered him UP3. So he said, I want to know where exactly the problem is. Can you help me? So I did a sleep endoscopy for him. So that's how he keep his mouth. Again, on your left, you can see that's a heart rate. Saturation is 85. Sleep study says 89, but he's dropped down quite significantly. That's a paradoxical turbinate on the CT scan. Deviated septum. And that's his status of his palate. Quite posterior base, funnel shape, and it's like a fluttering sound coming from the soft palate. Look at the base tongue, it's almost filling the vallicula. It is literally pushing the epiglottis. When doing the inspiration, the epiglottis and the hypopharyngeal wall try to create the space for him to breathe. But because of the Bernoulli's principle, as the epiglottis push backward, immediately because of the surface tension, it sticks to the posterior pharyngeal wall, it closes. So it gives me an impression that it's most likely the secondary epiglottis collapse caused by the bulky base tongue. So now I'm gonna do the Ishmarsh maneuver or jaw thrust. So by doing the Ishmarsh maneuver, I see that the soft palate came forward. The collapsible retropalatal space become a fish mouth, right? But it is also try to close. But you can see the tongue base is slightly stabilized. But with a heavy inspiration, try to see that the epiglottis is not supporting much. Tongue didn't come up forward. But the hypopharynx, I can say, a little bit stabilized a bit just by moving the jaw. The tongue is still there. I go a little bit forward. The time I release the jaw, I recorded him around 30 to 45 minutes. So after, in between the maneuvers, I give the time for the patient to go into the proper sleep stages, and then I go ahead further. So now I'm turning to the left lateral. You can see the tongue is rolling over the lateral wall, and of course it's gonna push the epiglottis. So as per the sleep study, it doesn't have AHI bad. Look at how his airway behaves in the left lateral. Still the collapse continue at the level of base tongue. I know the epiglottis is a bit floppy, but still I'm blaming the tongue. It's responsible for the epiglottis to collapse. That is what is my observation. So again, in the left lateral, I try to pull the jaw forward like a Ishmarsh. I see that the palate little bit came forward, so oblique view. Time I release, everything start collapsing. So it gives me an impression that he may be a good candidate for give him some oral appliances, but it is not gonna sort out the problem because the nose is quite blocked, congested. Then I put him on the CPAP. Let's talk about the tongue palate interaction. Look at how the tongue is folded. Create some rescue breathing, but uvula is sitting exactly over there. I pull his jaw forward a bit. I've seen that he still has a snoring. Tongue is little bit stabilized by Ishmarsh, but the events still continue. That's on his left side. That's the concha. Now I put him on the 12 centimeter water CPAP mode. That's what I picked up on from the sleep ResMed 95th percent patient pressure is 12 centimeter. I started on the 12 centimeter. It creating some, it stabilizes the palate. It giving him some little bit of opening side wall that might be reduce the snoring, but maybe he need to take an extra effort to breathe. So I brought down to 10, more or less the same. With the CPAP 9 centimeter, I moved the jaw forward. I found that there is improvement. Gives me an impression that if I put him on the oral appliances along with the CPAP is a good option. But he already did Invisalign treatment and he doesn't want oral appliance. Even the 8 centimeter helped him that CPAP to work. So depends on the depth of the sleep, or I can say the REM sleep, the CPAP really need to take a lot of effort. I simulate like a chin strap just to close the mouth and see the dynamism of the airway. It is not changing much. CPAP still need to work hard. So that's how sleep endoscopy. Hey. So that's what he's using, a P30 mask, and he doesn't want it. He said it's creating too much trouble for me. Can you help me? So of course I need to help him with this. Tongue is flickering. He has a tongue tie, grade 2. So yeah. So by the way, before I start, any comment about the sleep endoscopy? Dr. Srinivas, Dr. Hisham, Ahmad, any comment on the sleep endoscopy? Anything you picked up other than what I've noticed?
No, I think
I think he's just very hypotonic all around, like from
Yeah.
the soft palate all the way down to the epiglottis. Whenever I see this kind of picture on a dice, I'm very wary of, like, honestly, all of the surgical procedures because he's at high risk of failure,
True.
including, honestly, maxillomandibular advancement. When he has that kind of flaccid base of tongue, that's usually where most MMAs fail. They fail in the hypopharynx. So I'd be very careful. I would take a step back, maybe have a more holistic approach in terms of like assessing him. Uh, I think that myofunctional therapy might be something that is worthwhile considering in this situation. I'd be careful of releasing his tongue tie because releasing his tongue tie can potentially make his base of tongue flop backward even further. But if I'd had to have to do anything surgically to this patient, I would start with a single level. I would start off with the soft palate first, wait for 3 months and see how he responds to that before anything like more aggressive, like a maxillomandibular advancement or anything like that. And after the soft palate, we can always consider an oral appliance.
Right. Tina, would you like to comment on the tongue tie and the myofunctional therapy, oral appliance?
Yes, sure.
Yeah.
Unfortunately, because of my poor internet connection, I'm not going to switch on my video. I missed a bit of the presentation as well around that. But I liked what Dr. Ahmed was talking about, like this hypotonic type. And I do think that, because we are limited by what we see just in that pharynx, we are often missing out on whole body pictures. For example, I'm seeing a lot of patients with hypermobility presently, and these patients are presenting with a lot of weakness in the oral musculature, which, if we jumped into more surgery, into more tongue ties without actually taking into consideration what is going on with the whole body, we may, not land up with the results that we want to see. Overall, I wish Dr. Baptista was on the call. His book with Dr. O'Connor about the treatment of the use of myofunctional therapy in treatment of snoring and sleep apnea is really an incredible work. The latest study in January, which I really can't stop talking about, is just wonderful to show that despite CPAP or other surgical interventions, myofunctional therapy will continue to be a good adjunct to the procedures that we offer, whether
Uh,
that is sleep surgery or whether it is even with oral appliances, because when we
mhm.
actually get the tongue out of the airway, we are going to reduce epiglottis collapse as well as tongue base collapse. So, considering this gentleman's significant tongue tie frenum, even if the tie was not released, myofunctional therapy should really be added on because of the hypotonic view during the DICE.
Dr. Tina, do you think so? If you release the tongue tie, that will improve the effectiveness of the myofunctional therapy. Do you think so? The tongue tie is one of the reasons for his having the hypotonic tongue. If you release it, we can make it more mobile and we can give more effective myofunctional therapy. Am I saying correctly, or you want to make it correct in a scientific way?
I feel like we know that answer only after the patient has undergone myofunctional therapy. So I'm a
Okay.
very strong believer that while the diagnosis lies with surgeons and with dentists, a big reason to release tongue ties is if the myofunctional therapist is noticing compensations during the exercises. So if we are seeing that now the frenum is actually restricting them, that's when we release tongue ties, because it is rather surprising to us who do tongue tie releases that when patients undergo some few months of myofunctional therapy, sometimes in adults it can be even 5 or 6 months, you kind of feel now that, hey, the tone has improved and I do not see the frenum as restrictive as before. So it often
Yes.
shocks me as well, where I'm like, no, I think we should just pause, and we have achieved the maximum that we can in positioning. So the release is not always the answer. Myofunctional therapy is very often the answer.
Yeah, but just to add on, he's having a quite significant symptoms, high risk of other comorbidities. So just limiting the treatment to the myofunctional therapy or oral appliance should not be an approach. So it should be a multidisciplinary. So do you still advise patient to continue with the CPAP with this myofunctional therapy or oral appliances? Or how you take it further? Or you ask them to stop using the CPAP and go ahead with the myofunctional or oral
No,
appliance?
no, no,
No,
no. Okay,
no,
so
no.
myofunctional therapy will, for a long period of time, continue to
Okay.
be an adjunct in these patients that we are
Excellent.
catching pretty late in the game. So it
Okay.
cannot be the mainstay of treatment. Recent paper 2024 on dental
Mhm.
standards uh, guidelines has been very clear that we need to be, there's insufficient evidence. So am I a fan of myofunctional therapy? Yes, but can it be the mainstay of treatment in this case? Absolutely not.
Okay.
But if we start to have patients wake up with their mouth closed, with the tongue in the right posture,
Mhm.
then that is reducing CPAP pressures, improving outcomes from from oral appliances as well.
All right. Um, so Jesse or Nicole, considering he's having a significant deviated septum, hypertrophic turbinate, concha bullosa on one side, a paradoxical medulla, do you think so? If we do something for the nose, it will increase the not in terms of compliance, but the effectiveness of the CPAP in this patient? Is there any role of the septoturbinoplasty in this patient?
Yes, I agree in general, although I have to say in this particular patient is not like severely deviated at septum. There is some, but I love treating the nose. In On the other hand, I agree also with Tina. I never touch tongue tie, I never release a tie unless they've done myofunctional first, because if not, that's destined to failure, and it can just get worse. So I think this is not like a one single decision and one guided treatment alone. No, you have to
Yeah.
work as a team. So there's no one way decision. And yes, there's a lot of weakness in the tissue and it's collapsing the airway. So definitely I think myofunctional therapy will help him. Definitely helping fixing the nose will give him a better adherence to the CPAP, together with the myofunctional and the tongue tie release.
Right.
And
Yeah.
maybe something else if we are
So,
going in, no?
so just to add on, so if we are offering him the nose surgery, do you think so at the same time we should release his tongue tie? or any other
Uh,
differ on
I
this one?
do often because it's a simple procedure, and then instead of doing it, but not without the clearance from the myofunctional therapist.
Okay.
So
Dr. Ahmed, are you differ in this? You said, we should not release. Are you gonna touch his tongue tie if you just want to do the nose job for him?
Not typically, because sometimes changing the dynamics of the airway in the nose can potentially change how the hypopharynx responds.
Okay.
And just like what Dr. Rakadia said, I would have him do myofunctional therapy for 5 to 6 months
Right.
before making a determination on his tongue tie.
So you're not taking the advantage of anesthesia for nose to just release the tongue tie, right? No.
No, not typically. And
Dr.
honestly,
Dr.
like if I had to release the tongue tie, I can do it under
Uh-huh.
local.
All right. Right.
Yeah. Just
So yes, Dr. Srinivas.
I think, yeah, just before we, close it, I just wanted to say something that, okay, so this patient, right? So now he's in the right age,
Yeah.
and the severity in terms of disease burden seems to be very high. So whatever we do, I think initially he would tolerate it at this age. Um, to me, because of course this is a process, and like I say always, that OSA is a journey, I would definitely do the most effective thing to reduce his disease burden first, and then offer all the adjuncts as we progress. Yes, I do agree there's a definite tone issue, but the tone issue is a consequence of multiple things. And I still do definitely see, looking at how the tongue is falling, is definitely a high tongue base obstruction. And it's definitely the box issue. And I would first do an MMA and then slowly work with myofunctional therapy, and do also the nose in the same session as the MMA, and then proceed, because you want to reduce the disease burden to the patient ASAP, or
Yeah.
keep giving the CPAP if he's happy using the CPAP, but then you said he's not happy using
No,
the
he's not
CPAP.
happy. He's not happy.
So if he's not happy using the CPAP, I don't think he will be very adherent. And then, if he's not adherent, and we do these things very slowly, step by step, 6 months, the disease is not going to wait for us. I
So
would like to do the most effective thing first, and then follow through with whatever comes and try to improve things based on what is left.
So, Dr. Srinivas, when you do plan for the MMA, for example, would you like to offer him to do the septo turbinoplasty as well at the same sitting?
Yes, at
Right.
the same sitting.
Dr. Ahmed, do you agree with this one? So, would you also like to offer him MMA, or
So
you have some different
I would
in mind?
I would love to honestly
Okay.
offer him MMA. The only problem is he's at a very high risk of failure. Those hypotonic patients, you really need a very large advancement. So you need at least 10 to 13, 14 millimeter advancement. The issue is if he was class 1 to begin with, that will result in a suboptimal aesthetic appearance. And that would be my worry. And like it seemed like his bite or occlusion, at least from all of the orthodontic treatment, is okay. And sometimes you can also worsen that. So with a high degree of advancement, you can have you can actually create a surgical anterior open bite, which can be catastrophic. So you're trading his airway with issues with mastication. So that's why I'm a little bit hesitant to offer him
Yeah.
an M.
Just to add on to MMA, so MMA is not that feasible or approachable for all the sleep surgeons. So it's very much institute based and all. So of course he's concerned about you reduce the severity of the apnea. He want to also reduce the severity of the snoring and all. So do we think so? We can also offer him some palatoplasty, Dr. Hisham. Uh,
Thanks, Shailesh. I think first of all, I'm very happy that patients are getting more aware about what's going on, and they come seek like opinions before rushing into just cutting the palate, as always the case. Because as we see here, the importance of identifying this phenotypic sort of patient, which is like the muscle tone. I think I would rather initially like approach it as all of you said, multidisciplinary, add to it weight reduction as well, because we know that the fat infiltrates as well the tongue. So though he's only class 1 obesity, but still might add up to the sexes, definitely nose is an issue. So I think it will improve his CPAP, maybe adherence, tolerance, and maybe sexes as well. Because if the nose is blocked, he will open his mouth and tongue will fall. So it's like a vicious cycle. So I think these needs to be addressed before rushing into the palate. Because if we subject him to, relatively speaking, a painful procedure and yet he doesn't find an outcome, then that also might discourage him.
Right. Anyone can like to do, nose, palate together in this patient, or Dr.
Yeah,
Srinivas?
I
Yeah,
could talk.
yeah, go ahead. Go ahead,
So
Ahmed.
if the patient, he doesn't want to go MMA, all right, Dr. Ahmed also mentioned that there is about cosmetic and other issues. So if you want to offer him something to make the things better, would you like to do the nose and palate together, or you only just want to do the nose at first place,
No, honestly, I would do them both together,
both together?
as a start. Yeah.
Any technique would you like to prefer in this patient regarding the palate? Because UP3, I think nobody does that nowadays. But any particular technique you're going to use in this patient having such a thick palate, kind of a triangular collapse, big
Yeah.
tonsils, grade 2 endophytic, a big posterior pillar, thick posterior pillar?
So,
Just
so
a quick comment.
yeah, two goals that we need to achieve. So we need to achieve lateral expansion and anterior to posterior advancement. So typically what I would do is a combination. So I would do an anterior palatoplasty, probably like a pretty generous anterior palatoplasty, like maybe about a centimeter or so in length, or a couple of centimeters actually in width, and around half a centimeter or so in length. That kind of advances the soft palate forward, and then just expand the lateral aspects of the oropharyngeal wall as you would, like either with a barbed or with regular sutures, however technique. There is an additional aspect that I would also like to do in these kind of patients. I'd like to suspend the soft palate to the hamulus, kind of shortening it
Okay.
as well.
Okay.
And that creates a little bit more cross-sectional space
Okay.
from a technical standpoint.
Right. On the sleep endoscopy, we see that his tongue base is bulky, is filling the valvula. So it is easy impression to come to, as a sleep surgeon, okay, let me reduce the base of the tongue. So how you take it? Do you think so? I should think in that line to reduce the base of the tongue in this kind of patient.
It's a high tongue base, Shailesh.
Yeah.
It's if it's a low tongue base on dice, then you would be very correct. But it's a high tongue base, basically just floppy and falling
True.
back. Removing as much, I mean, no matter how much you release or take out,
It's
it's
not gonna work.
not going to help.
Right.
And I think, again, from even a point from your dice, is that while you're doing your CPAP titration with your dice, it's very clearly shown that it's very easy to open up the soft palate. But
True.
when it comes to tongue base, CPAP struggles.
True.
And
True.
that's what I think that's what even literature sort of supports.
Yeah.
So something obviously has to be done for the tongue to probably not fall backwards. So maybe you could do the palate first, and then since you guys have the hypoglossal nerve, why not do the hypoglossal nerve implant? What stops you from doing that?
All right.
100% agree. That was
Okay.
my
So Jesse,
point.
I'm sorry
Yeah,
to interrupt you. See, that is what I put it at the end. So Right. So I'm about to call you. So do you think so? You gonna offer him hypoglossal nerve implant uh, without touching his nose and palate
Uh-huh.
before? Or
Uh,
second question is that would you like to offer him a MAD first? But of course he refused it. MAD first and see how he's responding and all. Then you're gonna involve max-fax surgeon. Or would you like to simply go ahead with the hypoglossal nerve implant for this patient? You want to prepare his nose palate first for a better response, or are you gonna simply offer
mm,
him hypoglossal? But before, and I
this
can
is
say
what I,
that is he a good candidate for hypoglossal nerve stimulation?
he is, but first I would do the nose, of course, optimize that, and probably what I would do with the nose would be the tongue release before thinking about the implant, okay? And eventually give him like maybe 6 months of myofunctional therapy and reevaluate. If we persist with the symptoms, why not? The hypoglossal nerve stimulation, the bilateral, has excellent response on this case. I would have offered, of course, but now we have to be very aware that patients don't always want to have an implant inside, no? So probably if we go by steps and offer different options and give information to the patient about what the patient should expect, maybe we can go by steps, and then if the first steps are not working as good as, because probably they won't, then let's go for the implant. It will be great. And
Okay.
also he's young, so it
Yeah.
will be a
So
very good
now,
response.
so to conclude this case, so I'm gonna ask Professor Hisham, how you gonna arrange the management plan for this patient, in the phase wise? And the same question I'm gonna put it to Dr. Srinivas. How you gonna arrange the management for him in a stepwise manner? He's on a CPAP, severe apnea. You want to address his apnea. You want some substitute to reduce the problem. So how you gonna go ahead if you pick up all this treatment plan? Professor Hisham, I want to listen from you first.
Well, it's very interesting because everybody said, and it's very nice. I mean, it's complementary the way we address the patient. That's the value of such meetings. I think, as said earlier, nose needs to be addressed. Weight reduction, myofunctional therapy, um, palatal management, staged depends, as we said, and then tongue uh, can be addressed as well subsequently. So
The
that's
tongue
what
in
I
terms
think.
of surgical call or myofunctional and tongue tie release? Tongue-based
No, I mean
reduction?
like myofunctional therapy and
Okay.
tongue release subsequently, and then if things doesn't work and like elsewhere he's improved, then we can think about the implant if he agrees on that, of course.
Right. Just one question click in my mind. Dr. Tina, he did some Invisalign treatment. Do you think so in the future we can convince him for the oral appliance as well? Is it possible? I can refer to him as well.
Yes, definitely. Till
There
the
is no
occlusion,
limitations,
yes.
right? Even is not.
No,
Okay.
no.
Dr. Srinivas, professor, final comment, how you gonna, manage this patient with all these options?
So, uh, okay, different places have different sort of algorithms, right? I
Yeah.
think for me, I would definitely offer an MMA first. I would do his nose at the same sitting,
Okay.
then and make sure that he sticks to his myofunctional protocol. He does myofunctional therapy regularly. That's what I would that would be my sort of treatment plan for him.
Perfect.
So
I
on if I would have a neurostim, would I do that?
mhm.
Um, yes, probably yes.
Excellent. I got the three approach. I got from Professor Hisham, how he's gonna approach in a conservative way and addressing the soft tissue. I'm got an input from you. Are you gonna go ahead with the MMA? That is also a wonderful approach if institute allows. And also heard from the Jessica, patient is also a good candidate for the hypoglossal nerve stimulation if this is available, right? So same patients, similar phenotypes, but can be managed in a three different way. Oh, wonderful. Right. So I think we are 1 hour and 30 minutes for the meeting. Dr. Hisham, can we go quickly with these debate questions? Right, one next 5 to 10 minutes, if the panelists is allow me, then we'll conclude today's session. Is that okay?
Definitely.
So this is our debate question for today's meeting. DIAS versus awake endoscopy, a fair comparison. So, Professor, so can we do quick poll for this one for next 20 seconds? Can we have those questions, please? So this is about the guide for surgical decision making, awake versus DIAS, or both together. It depends on the patient. Second is how often does DIAS changes your original surgical plan compared to the awake assessment? I think on this, recently, Dr. Simab Sheikh published a good article, a huge series on the awake endoscopy versus DIAS. Base tongue and epiglottis does make a difference, but palatal, he said it's awake can help. And this is the future question. So how is gonna be awake with imaging, DIAS, AI-assisted multimodal, and completely new technology? Uh, can we have the outcome of audience poll, please? Right. So 73% out of 15 say uh, both together. And how often it changes, I think, is a mixed response. But around 40% they say occasionally. And yeah, multimodal assistant DIAS outcome. Right. Perfecto. Right. Okay, so that's the first slide. Professor Hisham, would you like to comment on this one, please?
Yeah, definitely. So actually, it's interesting to look here at the different domains that can be incorporated into the assessment of an obstructive sleep apnea patient. But for the sake of the debate today here, so we are concentrating on the left upper and right lower, which is DISE versus awake anatomy. And as we all know that awake anatomy evaluation will look into some, let's say, uh, and might be of help for simple, straightforward cases. However, DICE definitely is an important aspect because it does look at the dynamics in sleep-like, I would say, resemblance of what's going on. So it's more of dynamic. And uh, it's varied between the two. So I think maybe we can go for next slide for the sake of time so that we can. So if we look at the comparison between the two, so first of all, when it comes to the cost, so we know that uh, like awake tools definitely are more cost effective because they are readily available in the clinic. You don't need like an endoscopy suite, or you don't need an expert anesthetist. Also, yourself, like it's what we do every day basically. If we come to a sleep state correlation, then definitely also on the other side here, DICE will be a winner because we all know that DICE is like while the patient we scope him in the clinic, then his muscle tone is regained. He's more or less most of the time sitting, so it might not be as reflective of what's going on while sleep. While DICE goes more nearby that, we come to surgical predicted value, which is very important according to studies, as we all know that the chances, as correctly answered by our colleagues here, that DICE will change your line of management is at least more than 50% of the time. Now, given that said, then uh, if it did really change my line of management, does it reflect that it is superior or not? That's another issue, because there is very important, interesting uh, systemic review in the European Academy of for Otolaryngology, which speaks about, actually it reviewed more than 25 studies, and it included uh, more than 5,000 patients. And in that, it said that like DICE targeted upper airway surgery failed in like almost third of the patients. So still here, that's like an important thing to keep in mind as we do that. Okay, we are trying to approach the better solution, which is still, it is DICE, but also there is a limitation within that. And we come to reproducibility. When it comes to the awake tools, then it's more aesthetic and more reproducible, like the size of the tonsils, like Friedman tongue scoring. And like when it comes to DICE, then it depends on the protocol used. It depends even on the agent used. Actually, there are some studies which speak about that the pattern of collapse can change from one sedative to another. So that's also something needs to be unified and looked into. Um, and also, it depends on the position. So many things, variables are there. Um, so basically now, when it comes to the competition, are we really trying to say that this one is better than the other? Actually, in reality, it is not. Each one has got its own place. At great deal of time, they are complementary for each other. At many times, awake tools can be sufficient. DICE has got definitely a major role when things are not as straightforward, like if we are suspecting like lower airway collapse when it comes, I mean, to like the epiglottis, base of tongue, lateral airway collapse. When it comes to unexplained cases like failed operative cases, when it comes to unexplained CPAP failure or cases where CPAP made things worse. So all of those things are important to be kept in mind. So DICE definitely has got a value. It is part of the selective pathway of diagnosis. Like it does help us in phenotyping our patients. So the bottom line, both of them are important to be, both are complementary. I think it's important to look into the last question because it's not tackled here, which is to do with.
Yeah.
Can we go to the slide before this one, Shailesh?
Yeah. So this is the, I think, last slide, Prof. And there was a last question about the future, right? Future question.
Yeah, exactly. That's what I
Next
meant. So
in 10 years down the line.
exactly. So if we go to that question now, what's going to happen down the road? I think things, of course, it is not evidence-based answer, but it's more to do with futuristic expectation, let's say, because it's a trend that we can see heading toward, as I say. So definitely, we have like all the awake tools, the DICE. Even radiology will be incorporated into that. Okay, different parameters, snoring and airway signals. AI will kick into action. So I think down the road, it will be like a multimodal sort of evaluation for our patients rather than this is versus that.
Right. Perfect. Dr. Srinivas, any comment? Do you think so? The comparison between awake endoscopy versus DIAS is too early because awake endoscopy we are doing for a long time with some Muller's maneuver, but DIAS itself have a lot of dooms. We don't have yet standard protocol. We are not sure about the medication. We are not sure about so many dooms are there. So do you think so it is very difficult to compare at this moment awake versus DIAS? Or what is your take or take home
I
message for
think
us?
I think they're mutually complementary. I think they sort of complement each other because what you didn't see in awake endoscopy and you're seeing in DICE, and if it's not making sense to you, obviously somewhere you're going because DICE is very procedure dependent, very personalized, and of course, there's a lot of literature to support again that there's difference in how an experienced surgeon and an inexperienced novice surgeon would interpret the same DICE. So it's very personalized, very sort of lot of ifs and buts at this point, and the biggest but is that DICE can never predict the behavior of the upper airway in REM sleep because no drug can give REM sleep, right?
Wonderful
So
take on
if
this.
you have any REM predominant OSA or a woman that you want DICE to sort of solve, I think there again there is a problem. So I think they're mutually complementary. But I think the future is all going to be based on how the flow limitations based on different levels would show on your PSG.
Yeah. Okay.
And with your dice seeing that probably would be the future.
Wonderful. Thank you for your input. Okay. So I just go ahead to wind up to just showing upcoming meeting. I think most of them are going to Istanbul and global sleep surgery. September, I think everyone is coming from this meeting. Yep.
Yep.
I'm not sure about Ahmad
Yes.
is visiting from Riyadh. I'm not sure.
Yeah, definitely.
And yeah, great. And October we'll have a meeting, but I think because of the situation, we're gonna, I think, change the pattern of this Mioto Academy meeting in Dubai. California is happening again, ISSS, and ISSA meeting is happening in next year, February, right? I think that's all about the today's meeting. So we will have a cadaver dissection course. Still is on the board, 1 day course. So Vijay Krishnan is coming with Peter Baptista. We try to do it 1 day full comprehensive sleep apnea course and so on. So thank you very much. So just at the end of this today's meeting, I sincerely thank to all my faculty members and my colleague and participating is very valuable. I would like to express my gratitude to Edward and his team, marketing team. They are doing all the work behind about the marketing and making this event happen. I also thank to Professor Moaz Tarabishi for my mentoring and supporting me. Iyad is the CEO of Tarabishi Healthcare Group. And nevertheless, my delegates, they are always there to be the part of it. Thank you very much. I think because of the time constraint, almost 1.5 hours, more than that, we are having this meeting. So I may not be in a capacity to take a question. So I think we can conclude this meeting today, right? Thank you very much for everybody to joining us. Highly
Thank
appreciate that.
you.
Thank
Thank you.
you.
Thank you, Dr.
Thank you
Shailesh.
very much.
Good
Thanks.
evening.
Thank
Thank
you
you
You're
for
for
all the
hosting. Bye.
interactions.